It is now my pleasure to turn today's program over to Charles Gluck. Mr. Gluck, the floor is yours.
Thank you very much. Hello, everyone. Thank you for joining us. I want to welcome you to today's learning event on advanced care planning. As always, type in your questions throughout the webinar. We'll get to as many as we can, and for those we aren't able to answer, we'll provide additional information on CPC Plus Connect, as well as in the frequently asked questions you receive in our weekly On the Plus Side newsletter. And now I'd like to turn the presentation over to Amy Gibson.
Thanks so much, Charles, and welcome everybody. We're certainly glad to have you with us today. We've got some great information to share with you. I know many of you have been anxiously awaiting to hear more about advanced care planning and CPC Plus, and this is your opportunity. Got phenomenal speakers with us today that have a lot of information to share with you. So we want to get started pretty shortly here. We have Dr. Laura Sessoms with us and Leah Hendrick from the CPC Plus CMS team. We also have two phenomenal practice speakers with us today. We have Dr. Hillary Lum from the University Physicians in Colorado and Dr. Georgia Newman from Oberlin Internal Medicine Associates in Ohio. We're going to meet them a little bit further into our presentation and learn more about the outstanding work that they're doing with their patients on advanced care planning. So I just want to give you a quick overview of the information that we're going to cover. Again, we've got a lot of information to share. We do really encourage you to ask questions throughout the presentation. So go ahead and chat those questions into your question pod. We're going to save some time at the end to do some live Q&A with all of our speakers on today's presentation. And then for those questions that we're not able to get to, we'll love to continue the conversation with you on Connect. We've also got some great resources available for you here. You can go ahead and download those directly from your files pod, but we'll also carry those over on to Connect. So you don't have to spend all your time furiously taking notes. We'll put all this information over to where you can access it after today's event as well. So today we're going to cover a lot of information around advanced care planning. We're going to talk about how you can really identify some of those benefits to advanced care planning with your population. We're going to talk about some of those strategies that you can really employ in your practice to identify those patients who would most benefit from advanced care planning discussions. We're going to talk about some strategies on how you can initiate these conversations. These are tough conversations to have about serious illness, and we're going to give you lots of great information about how you can start doing that work. And then, of course, how you can start to really integrate advanced care planning into your overall practice workflow and involve other members of the care team that are so critical to doing this work. So that's a lot to cover, and with that being said, I don't want to waste any more time. I want to turn it right over to Dr. Sessoms to get us started. Dr. Sessoms?
Thank you, Amy, and I'm going to let Leah Hendrick here, who's the CPC Plus team co-lead, start us off.
Thanks, Laura. Just echoing Amy, thank you all for joining us today. We're really excited to talk to you a little bit about advanced care planning and particularly have some practices share with you some information about how they're implementing this in their practice. But first I want to start with just a little bit of high-level information about advanced care planning. So first, what is it? Advanced care planning is a process through which you help your patients make plans about the care that they want to receive if they become unable to speak for themselves. And everyone on your care team really has a role to play in advanced care planning, which Dr. Sessoms will go into a little bit later. But really just to focus on the overall goals. The goal is to have a conversation with your patients to help them identify their preferences for care at the end of their life, and then to also document those conversations and preferences in a way that they're easily accessible and can easily be followed when the time comes. Also, just want to note that it's really important to have these conversations early. There are a number of benefits to having them early. First, it will certainly improve the quality of care, and it can avoid unnecessary or unbeneficial medical intervention. And also, really importantly, it can help to ease distress for families when the time comes. So really important to have them early, and again, Dr. Sessoms will talk to you about how everyone can play a role in this process. moving to the next slide, one of the questions that we get a lot about advanced care planning is how it differs from advanced directives. Like, are these the same, or how are they different? How do they work together? So just want to talk a little bit about the difference before we get into advanced care planning sort of in CPC+. So advanced directives it's about the documents. They are legal documents that identify end-of-life decisions, and they can include a number of different types of documents, from healthcare powers of attorney to living wills or multiple forms. So those are actually the legal documents that sort of document these sorts of decisions. But advanced care planning is a much broader process in which the care team discusses and documents the goals and preferences around patients' goals and preferences around their end-of-life care or care during times of serious illness. Ideally, advanced care planning conversations can result in the creation of advanced directives, but regardless of whether they do or not, these conversations should be documented in the patient's medical record. And again, just to reiterate, the ultimate goal here is to ensure that patients' preference and goals for care are considered during their times of serious illness or at the end of their lives. So now I am going to pass it over to Dr. Sessoms, who will talk more about advanced care planning specifically for CPC+.
Great, thanks, Leah. So as with all work in CPC+, our goal here is to begin our work, for you to begin your work in a small and targeted way. And that allows you to focus first on the patients who can benefit the very most from advanced care planning. It also means, of course, you're using your resources wisely and allows you to fix early any problems that you find in your workflows, to address training gaps and the like before you enlarge your target group of patients. So to start off, you want to identify this small subpopulation, and you might start by looking first at your patients with serious illness that you identify through your risk stratification process. And then you can further limit your subpopulation to those who could benefit most from advanced care planning, like those with advanced age or a life-threatening illness, or even both. So why is this a requirement? Well, personally, I am very excited about this work starting in CPC+. The opportunity and obligation that we have to improve care at the end of life is really important. Yet we all know that these advanced care planning conversations can be emotionally charged and time-consuming, so of course they frequently don't happen, or they happen too late. And as a result, we're not providing care that furthers patients' goals, and patients during this incredibly vulnerable time are not getting the care they want at the end of life. Given the trusting relationship between patients and their primary care team that's the heart of primary care, practices in CPC+ are perfectly positioned to engage in advanced care planning. So how can you begin, or if you're already doing some of this, maybe rethink or refine your advanced care planning work? Shown here is a stepwise approach for you to consider. And I want to point out that we have 4 high-level practice reporting questions on advanced care planning in the portal that follow the approach shown here. So first, planning. You want to number 1, use your data to determine the small group of patients you're going to start with who you think are going to benefit most from this work. Next, you're going to need to figure out a way to document your advanced care planning work, and this can be really hard for many. And you want to, of course, document the conversations and also any documents that result that Leah talked about, the legal documents. And ideally, this would all be in your health IT, so they can be easily accessed for clinical use by the whole care team, and also for use in quality improvement as you work to refine your advanced care planning process. Then you want to assess your training needs and resources that you have for all the various people on the care team who will be involved in advanced care planning, and then ways you might prepare patients for the conversations to come. And then develop a workflow for advanced care planning, including whether you're going to work towards patients signing advanced directives or related forms. And then finally, start the work. So So now Amy's going to introduce the CPC Plus physicians who will tell you about how their practices engage in advanced care planning.
Yeah, thanks so much, Dr. Sessoms. And this is our opportunity to really learn how this work is being done in practice. And so we've got some great speakers with us. I want to start with Dr. Hillary Lum. Dr. Lum, can you introduce yourself? Tell us a little bit about your practice and some of your special interests in advanced care planning.
Hi, it's great to be here. My name's Hillary Lum. I'm a geriatrician and palliative care physician. I am part of a primary care practice in our University of Colorado hospital system, and I also do research related to advanced care planning, and especially thinking about how we can provide additional options, especially in the primary care space, for advanced care planning interventions. So excited to be here.
Thank you, Dr. Lum. And we also have joining us today Dr. Georgia Newman. Dr. Newman, introduce yourself and tell us a little bit about your practice and how you got interested in advanced care planning.
Well, I'm sort of the opposite of Hillary in that I'm in a solo practice in Ohio. I'm also a geriatrician, but I'm sort of, as a geriatrician, finding that most of my patients actually qualify. I mean, finding this small subset when the average age of your patient is 85 to 90 is a little tricky. So I'm trying to develop ways to do this. And I've been interested in hospice and palliative care for many years. So this is right up my alley in a sense.
That's fantastic. Yeah, with the patient population that you're serving, it makes a lot of sense that you've really been thinking about how to do this work in a more concerted way in your practice. So we're anxious to hear more about how you're doing that. But let's talk a little bit more about some of that foundational information, and then we'll bring it back to all of you to talk more specifically about how you're accomplishing that in your practices. So Dr. Sessoms, tell us a little bit more about this, identifying that particular subset, that population that really would benefit from doing this work.
Great. Yes, so we've discussed the goal of beginning advanced care planning in a small and targeted way that allows you to focus first on the patients who can benefit the very most. Obviously, that can be difficult if you have a very high risk or population or one of advanced age, but I'm sure you could still pick your top few that you want to begin the work and quickly refine it and move to the next group. But to begin to figure out how you're going to start, we suggest you look at your risk stratification and see if you can identify patients within your highest risk group who will benefit the most. And as I say, advanced age, life-threatening illness are similar, and then start with this subgroup. So, Dr. Newman, I want to turn back to you, and given what you've described about your advanced age patient population, can you explain how you target patients for advanced care planning?
Well, the first place where I target it is when I see them in the office, and clearly I can see at a glance whether they've actually dealt with advanced directives or not, because it's either there or not. And if they're not sort of ready to hear things, you know, I have given you two of my handouts that I use, and I have found that one particular 9-page handout that I've used for so long, I have no idea where it came from, is very helpful because it's all about what important issues need to be communicated to family, choosing a spokesperson, what would you want to have done with your current health, what would happen if you were severely demented or you had a major stroke or had a terminal illness, and then it actually, how would you like to spend your last days, and asks questions. And each one of these pages has a little initials and date. So I give this to patients as homework so that they can discuss this with a family member and then bring it back to me, because it sort of documents what their wishes would be. In addition, we are already identifying our people just as everyone else is, because we have risk stratified. I'm using the Medicare 4-tier risk. So we've already been communicating with the level 4 patients, and I have another sort of set of questions which are, again, directed at healthcare goals, and that's the title of it, healthcare goals, which are the specific questions that the care coordinator can ask if someone is interested in pursuing advanced directives further. And this is from the Journal of Palliative Care and Hospice, and it was questions that were found to be probably the best at eliciting some answers. So I'm working in the background with my care coordinators, going through, every patient they touch. One of the questions is, do you have an advance directive or not? And if they do not, do you want to speak with someone about it? And I also have hired a lapsed pediatrician who's gotten involved in palliative care and end-of-life spirituality. And so she's very willing to talk to people and even make home visits to further discuss end-of-life needs.
So it sounds like you have a very well-developed process for this and already have a lot of your patients who have engaged in advanced care planning and actually have legal documents that set forth their goals and wishes. Would you recommend that practices begin with patients in the office, or go use their risk stratification and reach out to identified patients
I think you
in
need
the subpopulation?
Yeah, I think you probably need to do both. I mean, I can sit there in the office and I'm thinking to myself, would I be surprised if this person deteriorated or died in the next 6 months to a year? Boom, that's the one I better make sure that they have something. Because I think it's more than just picking somebody who will speak for you and knows what to do if you can't speak for yourself. It's also about how aggressive the care that you might want to be receiving would be, because somebody who can't speak for themselves might have a stroke and can't talk but is going to recover in a month. So it's more inclusive than just not being able to speak for yourself.
Those are excellent points. Thank you. So let's talk now about the overall advanced care planning process and how it can and should involve all members of the care team in various roles. And Dr. Newman talked a little bit about how she's using care team members in this process. I do want to point out, though, that the advanced care planning process should include a conversation between the patient and their practitioner about the patient's values, goals, and care preferences in the individualized context of the patient's medical circumstances and prognosis. These conversations typically begin with open-ended questions and can happen over time rather than sort of a one-and-done approach. And then when there are significant changes in a patient's health or other circumstances, it's often time to revisit the conversation, perhaps using that question that Dr. Newman just mentioned, would I be surprised if this patient dies in 6 months or a year? And so you also want to be sure patients are prepared in advance for the conversation, as that can make the process much, much easier. So I want to turn to Dr. Lum and ask about how you prepare patients for conversations on advanced care planning, and how often do you have these conversations and where do they occur?
Thanks. So as mentioned, I'm part of an academic practice, and we are able to use our Patient and Family Advisory Council to help inform where they as patients and family members would like us to introduce or bring back up the conversation. So we have engaged them in conversation, and that helps us to learn that they'd actually be happy for the conversations to be started by medical assistants and then in a warm handoff be followed up with by their practitioners. And then also in terms of preparing, they're happy to receive in the Welcome to Our Clinic letter a reminder that we care about their advanced care planning documents and an encouragement to even bring them in when they come in for their first visit. Another option that has come up that we've worked on, and I know many practices are using, is advanced care planning within the annual Medicare wellness visit. So we have a sense that individuals are sort of ready to comprehensively talk about their health, including those advanced care planning conversations. So it seems to be a time of openness. And then finally, because I know that many practices have had some experience with group medical visits, whether it's centering pregnancy or a diabetes group, one of the variants of that we have started is an advanced care planning group visit that's 2 sessions focusing on education and some of the early preparing or getting ready to start setting goals for advanced care planning. So it's not yet that individualized conversation that you were talking about, Dr. Sessoms, but it is a way for individuals to, in a safe place, ask a lot of their questions and share experiences, acknowledge their challenges, and then be more ready to have a one-on-one conversation with their primary care provider. So that's sort of an example of how we've been preparing patients.
That's great. And so I heard you talk about this is included, or the question about advanced directives is included in your clinic orientation materials for new patients, that it's something you have structured in your workflows for the annual wellness visit, and then the group visits to orient patients to this work. Can you talk a minute about how you set up your group visits and how do patients receive those? How does it go?
We have set up our group visits so that they're open to any of our primary care patients. We have flyers that allow people to sign up for them so they can self-refer. And then also, I'm currently facilitating them with our social worker, and the other providers in our practice can refer their patients to me, so that I'm sort of like a consultant in that way within our primary care practice. We've done these now for a few years, and patient feedback is very positive, encouraging others to participate. And then we've also seen patients bring in documents, complete documents, or have follow-up conversations with their primary care providers. So that's been our experience.
And it sounds like a very useful activity for everybody, all the primary care practices. Do you provide patients with educational materials in advance of the group visits, or they show up and you just start the conversation?
So we do use 2 specific resources, and we'll introduce these in the rest of the webinar, but to mention them briefly here, ahead of the visit, we send individuals a copy of the Conversation Starter Kit, which is available online for download, so that individuals have a sense of the type of conversations and value questions that we are going to be talking about during the group. And then during the group, we show some of the videos from a website called Prepare for Your Care, which has video stories giving examples from patients about having conversations and the types of decisions along that spectrum, both in terms of who you would trust and how you will link your values to the types of medical preferences and decisions that you are making for your future.
That's great. And do you notice a difference between patients who have accessed these materials versus those who have not when they come to the sessions or otherwise engage in the conversations?
You know, I think it really varies. We provide different materials because I think group visits embrace the fact that people learn in many different ways. So some people really eat up the materials and have looked at them ahead of time, and others haven't, and really appreciate the group dynamic and the interaction with Q&A during the session. So we provide them, and I think some people find them to be helpful.
Yeah, that's a really good point, that we're meeting patients where they are, and people learn and become educated and interested in something through different mechanisms. So it's not a one-size-fits-all, particularly given the cultural differences and emotional aspects of end-of-life planning. So I think that's a good reminder for all of us that probably a couple of different ways to approach and educate and prepare patients for these conversations is really important. I want to move on to another really important piece of this work, which is how to document it. And I know it's a perplexing issue for many, but obviously the goals of documenting is to ensure that the patient's goals and preferences for care at the end of life are retrievable by everybody on the care team, so that the care you're delivering in your practice is consistent with the patient's goals. So ideally, it's available within your practice, but in a perfect world would also be available to others who care for your patient, whether that's in an inpatient setting or another outpatient setting. Of course, the documentation is also really important so your practice can do quality improvement and thereby assess and improve your advanced care planning processes over time. Figure out who needs them, who hasn't gotten it, when it's time to update, how efficient are you at this work, etc. Another important point about documentation is that while advanced care planning in CPC Plus is about the conversation with patients, this discussion can lead to recording key patient preferences in a legal document, such as an advance directive, healthcare power of attorney, MOLST, or POLST form. And you really want to strive for a systematic approach within your health IT to ensure consistent documentation so everybody knows where this information is kept and where they can go to look for it if it exists, and if it doesn't, to begin to think about when to have the conversation. I want to turn now to Dr. Newman and ask you how, in your practice, do you document these conversations and any legal documents that patients bring into you?
Well, we have a place to scan in for power of attorney. That's listed under the information for the patient. As I mentioned, when I'm in my electronic medical record in the right chart panel, I can clearly see whether someone has an advance directive. In the state of Ohio, the 5 wishes is not legal. We do not have POLST. All we have is DNR CC or DNR CCA. Those are the only acceptable legal documents. So I can see living wills are also legal. So I have a way to click on what the patient has selected, and hospice would also fall under that, so would palliative care. So it would show up in the right chart panel that I can see it, and all those documents are then stored and retrievable.
That sounds very systematic. And have you been able to use, or have you engaged in any quality improvement processes over time? I know you've been at this for a long time, and so any advice for others?
Not really. I'm just figuring it out like everybody else. And I just realized, that my care coordinator who has been on the phone with the level 4 and level 3 people, and I created a whole template of questions because I didn't have much guidance from the EMR system. So, how are you feeling? What's important? What's your bucket list? It starts off with all that, and then it has the issues of the advance directives. And I just, she printed it up, and I'm just thinking, now wait a minute, how am I going to know of all those ones, which ones need an advance directive? I know that if somebody had said, as she's talking to them on the phone, they don't have one and they would like to talk to someone, she's forwarding that on to Joan, who's our palliative care consultant person. But I was just thinking, wow, I've got 2 boxes full of paper of all the people she's contacted. I probably should go through those papers and see, exactly how many people actually have it or have said anything about it, because unfortunately I'm not sure whether I can go back in the care modules and pick that out. I don't know that I can. I'll have to investigate that.
Right, and you're pointing out some of the limitations that many people have noted in their EHRs, and limitations differ, but advanced care planning isn't always the first thing that, it has not always been a focus for documentation in EHRs, so sometimes it can be a little unwieldy, and yet important to figure out who is documenting what where, and if there's an opportunity to get things on paper, as you're pointing out, Dr. Newman, into the EHR, that's very useful. And again, sometimes it's complicated, and practices find that one team member documents in one place and another documents in another. And how to make sure that everybody can access it is really important. You don't want to have a conversation with a care manager having a conversation and values are discussed, and then have the physician not be aware of where to go see that conversation. And this is getting a little bit into the next topic, but I think relevant if you could talk a minute about what the sort of questions your care manager talks about, how you've divvied up, I guess, what your care manager is talking about with patients in this context of advanced care planning versus what you or others talk to your patients about.
Well, I created, again, I think this was from the Journal of Palliative Care and Hospice, a healthcare goals discussion group. So it sort of leads off with, we want to talk about your wishes and goals if you were to become sicker. Next, we want to come up with a plan. We've all seen people who haven't gotten what they wished at the end of life, blah, blah, blah. So then the first question is, what have you been told to expect in the future with whatever their illness is? What does the future hold? And then their probe questions. And then if you were to get sicker, that's question 2, what would be most important to you? And these are open text blocks so that as she's listening to the patient, she can just type in, what do they want? Be cured, live longer, better health, maintain health, no pain at the end of life. Then in the next question is, what are you most worried about as you think about the future? Then there's a scale at the end of life. Different people want different things. Some people want to focus on comfort and quality, and others would much rather have everything done in order to live long as possible. Where would you be on that scale and why? And then the second part is making sure your family knows what your wishes are, making sure we as a health team know what your wishes are, and then what documents do you have in place? And where are them, and do we know about them? And then, we summarize it, put it on a form, and then what are your thoughts about how this conversation went? That's the last item. So that's all on our virtual visit, as we call it, and so all of those questions are there with the text blocks so that on the phone those questions can be asked to the patient.
That sounds terrific and very efficient. And then you see that thereafter?
Yes.
And how do you continue the conversation, Dr. Newman?
Well, again, if what I'm finding is somebody really wants to speak more about it or wants to create a document, what I'm finding in real life is, I'm sure what everyone else is finding, is the patients are coming in and the last thing on their mind is an advanced directive. It's, what about my shortness of breath, and what about my heart failure, and what about my diabetes and my type, stuff. So finding where to put this and how to put it is a trick. And it depends on where if I think they're really high risk and I'm really worried about it, I'm going to sort of interrupt some of the chronic disease stuff and sort of focus on it. And again, I have Joni who specializes and worked in a palliative care unit, so she's very willing to talk to people next if they want to learn more.
That's great. I want to go to the next slide and talk about in a little more detail what we've just been talking with Dr. Newman about, which is, and this is really a team-based set of activities like other things in CPC Plus, and that the whole care team can be involved in this process, including identifying patients with serious illness, setting up reminders to have the conversation, preparing patients for the conversation. As we just heard from Dr. Newman, care managers can start the conversation and help patients engage on these topics. And then, of course, helping coordinate documents and caring for patients after the conversation. And then the whole care team can be involved in thinking about and implementing a quality improvement process over time. So I'd like to turn to Dr. Lum to ask now who on your team is involved in care planning, and then what kind of training do you provide for staff in this work?
Thanks. So our team is 14 different clinicians, and so that's a lot of people going a lot of different directions. So we've really focused advanced care planning workflows on training medical assistants as well as our social worker, and to some degree, our care manager in really anchoring this process. So one example of a recent QI process that has worked for us with the medical assistants at the center is a pre-huddle where we incorporate a review of the electronic record for advanced care planning documentation at the beginning of the clinic, and then the medical assistant updates the clinician that advanced care planning would be potentially appropriate, plus actually gives a visual flag. So the medical assistant will add a one-page medical durable power of attorney document or a MOST form into the clinic door as a visual reminder to the clinician as they're going in to begin the visit that they could consider discussing advanced care planning. So it's just a brief trigger to help build a routine awareness of advanced care planning across a number of practitioners, so centered on the medical assistants. A second small workflow training is that we've ensured that all of our front desk staff know the different types of advanced directives in our states and are able to appropriately scan the advanced directives into the electronic record and update the documentation. So in terms of what sort of training we provide for staff, we have focused on being brief, practical, and focused to what that particular role wants to know, recognizing that advanced care planning is this broad process and that each person can be trained for a particular part, but also needs to know some of the context. So for example, for our medical assistants and our schedulers, knowing that these conversations can be sensitive or hard to start, we incorporate training into team meetings and have even created a one-page example scripting, and then we practice with some very brief role plays, sort of 2 or 3 minutes, that medical assistants can build into the rooming process, asking about advanced care planning and getting a sense if someone is open to wanting to have more of a conversation, and then the medical assistant can have a warm handoff to the provider. So that's an example of how we've incorporated training for staff.
That's interesting, and I note a couple different things in what you're describing, and one is that there appear to be roles that everybody can play and that allow everyone to have a part of this overall process, this broad process, as you say, and that it leaves the practitioner with available time and focus to have the conversation with the patient. And if that practitioner is charged with uploading documents or trying to remember to have the conversation, those things often fall through the cracks with the tyranny of all the other issues that patients are bringing in. So that sounds like a process that would work very well most of the time. I think the other thing I heard that seems innovative is the scripting and role-playing that you've done with the various team members. And I wondered if you could talk a minute about how that went and if that was something that was scary for people, or how you were able to overcome, if you had any resistance to overcome in beginning this process across the various roles in the clinic.
I think just like our patients, people are sometimes resistant and sometimes very open and just waiting for us to start the conversation. So among staff, there overall is an openness because they want to be part of this process, and they can, in most cases, tell that they've not ever been taught how to start these conversations. So there's really a readiness to learn and to be empowered in starting conversations. So overall, people have been receptive, and we've been able to even use the conversation starter kit in staff meetings. So individuals have been able to experience for themselves having opportunities to think about their values related to future medical care, and then it becomes more comfortable as they're initiating conversations with their patients.
Very helpful. Thank you. Leah, would you like to tell us now a little bit about some of the practice resources available for advanced care planning?
Absolutely. So turning to the next slide, or the one that you can see here, we have listed a number of resources that can really help primary care teams sort of begin this work and get training and find various resources to help. So we have them linked here. The top 3 are resources for primary care teams. And then below, you can see some resources for patients. So these are websites that you can sort of go to and find resources that you can make available to your patients to really start these conversations and to help them prepare for these conversations. So again, linked here, and I believe you can access these links through the Files pod in this WebEx. But I'd like to turn now to Dr. Newman and wonder if you can address some of the unique challenges of small practices and maybe make some suggestions how other small practices and practitioners in small practices can become more comfortable doing this work.
Well, obviously there's fewer people in a small practice. And I guess trying to figure it all out has been very difficult and has taken many hours of planning. I guess thinking about it is step 1. So all the people who have signed on and are listening right now, they're already prepared to take the next step, and we're hearing some really good suggestions from Hillary about the MA, starting the conversation, reviewing to see who has it and who doesn't have it, because everything that can be done sort of other than my being in the room with the patient, which is what I'm doing all day long, any time that someone else is taking a little of the burden off of me, it's probably a very good thing. So having a care coordinator, having a care manager, having MAs, and I guess we're all now having those because of CPC. That's the advantage of CPC Plus, is we have a few more people to help us than we used to in the traditional office. So assigning roles and scripting and figuring out what to do sounds terrific. I have to create some scripts myself, it sounds like.
Thanks. That's super helpful. And then now to Dr. Lum, I wonder if you can give the attendees on the webinar a little bit of information about how they might be able to get all members of their teams involved in advanced care planning conversations.
Sure. So I think that training is key in terms of thinking back to the workflow that we started this webinar with. And the resources that you have here on the slide are terrific because some of them are especially for clinicians, and they do include scripting. Especially Serious Illness Conversation Guide includes scripting. And then others can be very helpful for training in multidisciplinary settings and engaging the team and finding your champions so that you can then think about how you want to focus your quality improvement efforts. And that's where I really think, for me, the Conversation Project and Prepare for Your Care have been very helpful because they are resources that are readily available online and don't take a lot of time and can be the starting place for staff to have conversations about how then can we work on this for our patients. I've provided in some of the resources examples of how we've used the Conversation Project to train medical students, and also how the group visit was an opportunity to train residents. So many of you on the call are working in teams and also have influence and circles of influence with other learners. And these resources can be a way for you to start a project and build on it in terms of your workflows.
Great, thank you so much for that information. And then just one more resource that we want to point out to everybody is a day that's coming up in about just a little bit over a week, I believe, and that is on the next slide there, the National Healthcare Decision Day. And so this is a day that really emphasizes the importance of advanced care planning and can be a great tool that practices can use to empower their care teams to have these conversations with patients. And this website, if you go to this website, you can look around and find some really great resources to use to inform and really inspire your care teams to make advanced care planning a part of your practice. So this is a really great resource. I encourage everybody to take a look at this. So with that, I will hand it back over to Amy.
Thanks so much, Leah. Well, this has been an excellent conversation, and I know this is work that many of you are just getting started on, so we really appreciate already a lot of great questions that you've sent in. If you have some other questions, you can go ahead and type those in, as we've got some time reserved to have our practice speakers and certainly Dr. Sessoms and Leah to respond to those questions. Dr. Lum, we have had several questions come in asking more specifics about your group visits. So we know that those practices that are in Track 2 have access to the comprehensive primary care resources that can really help them fund these group visits in a way they haven't before. But you've already been doing these group visits. So can you tell them a little bit more about how you're financing those group visits?
Sure. So I encourage individuals who are interested to download the implementation manual. It's a work in progress, but I'm happy to have anyone who's interested in it look at that manual, and please email me if you'd like to have following conversations. But in general, these visits are billable as outpatient established visits, similar to how diabetes group visits, or I don't do centering pregnancy visits as a geriatrician, but I assume how those are billed also. So I don't use a special code. There aren't group visit codes, but these are billable. And I incorporate the team in terms of sustainability for outreach and enrollment of patients, to sign them up. The more you can set up practices for even perhaps permission, this is a routine part of our practice. We encourage everyone to take part in an advanced care planning group visit. That will help with your recruitment. That's been the hardest part in terms of sustainability for us, is to the logistics behind the scenes for the group visits. But in general, I have 10 patients per group visit. They're approximately an hour and a half with check-in time and then options for optional visits afterwards, so brief 10-minute check-in. And if I have that one-on-one time, I then also adjust the billing related to the diagnoses that I'm providing care for. And I document typical to other office visits.
Thanks for that, Dr. Lum.
Yeah, it's Georgia Newman again.
Yeah,
I believe there's no specific code or billable thing for a specific group visit. So traditionally, the group visit has involved a number of patients, and then you actually charge. So instead of seeing one patient every 15 minutes, you would see 10 or 12 patients in an hour and a half. But then each person must be seen and documented on in order to do individual charges. So the patients are all coming together. They all usually love the group ambiance, but there is no specific charge and fee for the group visit itself. So we're going to actually use CPC money for having group visits, because the problem with the traditional group visit model is that then you have to have extra time where you see each person. I mean, imagine somebody coming in for a diabetic group visit. They come in, you have to do their A1Cs, you then talk to them about their A1C individually, you have a talk about diabetes in general. I mean, it makes it a lot more cumbersome, and if you could use that money to have your assistants, bringing them together and you can talk to them, I mean, that to me is one of the ways that money would be well spent.
Thanks for that, Dr. Newman. Yeah, I think so. The CPC Plus funds obviously give all of you some more flexibility in terms of the staffing that you had to support these activities and your quality improvement work over time. And then again, for those of you on the line who are part of Track 2 practices, you also have that CPCP funding that's available for you that can give you some more flexibility around holding these group visits and providing that care in a different way. So we certainly encourage you to reach out and ask other questions of practices who are doing that work on Connect, and then also to your practice facilitators as well. And really appreciate everyone on the line offering up to have those conversations extended beyond this event as well. So thanks for that. And again, just we still had more questions come in about the resources that are available. So if you download the slides in your files pod for the presentation today, you have live links to go to all of those resources that are listed in your slide deck. We'll also be posting all of those resources over on Connect, and you can access many of them through your implementation guide as well. So again, thanks to Dr. Newman and to Dr. Lum for sharing resources that they're using in their practice that are made available to you as well. You know, a lot of practices in CPC Plus, one of our focus areas, as you all know, is really working to improve those transitions of care for patients. We got a great comment by one of our participants that is working on that by actually sending patient navigators ahead of time into the hospital to start preparing those patients for their transition back home. And they were asking if you, in your opinion, you think that it would be a good idea to start using some of these resources to initiate those conversations even while the patient's still in the hospital, and then to follow up with those conversations when they see their primary care practitioner in the practice. What do you think about that suggestion, and or as it relates to the best time to have these kinds of conversations? Maybe Dr. Lum, you can start.
I think it's a great idea and absolutely worth trying. We, in our transitions of care workflow, incorporated asking about advanced care planning and especially ensuring that it was accurate in the telephone phone call follow-up that we do within 2 days of discharge. And our experience was mixed. Some people were not as open as they would be then in the 7 or 14-day PCP visit because it was just so close to a challenging time in coming home from the hospital. However, there certainly was an opportunity to improve the accuracy of some of the documentation. So we weren't having robust conversations, but we were able to help with something. That was our experience.
That's great. Dr. Newman, have you had any experience with those transitions of care and using that as a point to start to initiate these conversations?
Well, I mean, I do transitional care visits, and I did a couple of them today. I don't typically at this time send somebody into the hospital, but I think that's a wonderful outreach. My problem is one hospital's one city away, another hospital's another city away.
Yeah,
I mean, they're not
right
in town, if you know what I mean.
Right.
So I'd have to be schlepping people out to wherever they are, and one of them I don't even know when people are in, so that's even worse. So, it's something to think about, because I think that would be a wonderful, warm, connection back to the practices. We care about you. The major complaint I see when I do these transitional visits is most of the time I'm explaining to the patient what actually happened in the hospital because they don't have a clue. Yeah. And they don't even know who saw them. One patient today said, "I don't think I was seen by a physician while I was there." I said, "Well, somebody dictated the history and physical." Well, could have been a robot. I mean, who knows?
Well, Dr. Newman, that brings up another point. It reminds me of something we were talking about before that we haven't spent a lot of time talking about today. We've certainly spoke to all the benefits to the patients who can benefit from these conversations, but in terms of bringing in other members of the family and how having these conversations, even if the family isn't present, how having these conversations early and often can really benefit the family and the caregivers for your patients over the long haul.
Yeah, I think it's absolutely critical. One of the patients I saw today can hardly get in or out of a chair. She's only got one kidney. She's blind from diabetes. She's 80 years old, lives alone, brought in by her grandson. And I'm thinking, talking with him, gee, I've been talking with her about an assisted living for a year, and she said, oh no, I'm fine. So having the family around that you can just express the concerns and then start getting into these topics is critical.
Yeah, I think whenever there's an opportunity to engage the family, and then as you had mentioned before, just having these conversations so that family members are aware of what the wishes are of their loved ones, it makes it so much easier when they're in a situation, certainly when they can't speak for themselves, but even after knowing that they did everything that was really what was preferred by their loved ones. So makes everything go much smoother, and everyone ends up getting more of what they wanted. So I want to thank everybody so much for their time today. This is, again, a conversation that we're going to continue to have over the course of CPC Plus. This is a lot of new work, lots of great resources that we showed you today, and we're going to be even bringing more to you over on Connect in the next day or two. So I really encourage you to go there. Ask questions of other practices as well, because as you heard from Dr. Lum and Dr. Newman today, there are already many of you, and I'm sure many on the line, who are already starting to do this work. Please share your experiences, what's working, what's not, what resources you found most useful, especially as you're really starting to provide more training to your staff that might have not had experience doing this kind of work before and are feeling really uncomfortable about it. Let us know what really resonated with them. Other practices would love to hear from your experiences. We really appreciate all the sharing that you do. Of course, we have many upcoming events still for CPC Plus. As always, we have our weekly practices in action, lots of great information that we're sharing there. And of course, our national meeting coming up in Baltimore. We really hope we get to meet all of you there. It's going to be a phenomenal opportunity to share all of the strategies and improvements that you've been working so hard on in the last year and a half really now in CPC Plus, and certainly to meet many of our new 2018 starters and share some of your experiences with them. So we'll give you an opportunity to hear and talk directly with those individuals who are not in your region and really get energized again about all the work that you're doing, because you're going to hear some great stories and some great strategies and ways that care is being improved for patients across the country. So we really hope we see you there. Just as a quick wrap-up, I mentioned all the resources. We're going to continue to talk with you on CPC Plus, Connect, and then we have information here so all of you can get your continuing medical education and your MLC as well for participating in today's event. We always appreciate your feedback. We really can't express that more strongly. We really are learning from you as much as we try to provide information so that you can learn from the experts on CPC Plus and the other practices that are doing this work. Please give us your feedback and spend just a quick minute to fill out the survey. We really do pay attention to everything that you tell us about what's working and what's not. So with that, I'm going to close out today's event. Thank you again so much. We look forward to talking with you again very soon, and have a great rest of your day. Bye-bye now.
And thank you to all of our participants for joining us today. We hope you found this webcast presentation informative. This concludes our webcast, and you may now disconnect. Have a great day.